with us now an ongoing good friend of the digital health community, Joris van Dam, who is also the head of digital therapeutics at Novartis Biosciences, and apparently sitting in San Francisco. Hi, Joris. How are you today?
Doing well, thank you, San. I couldn't find a Boston background, but hey, this is the way we travel these days, right?
That's
Through our
okay.
virtual backgrounds.
You know what? We're in New York, so the Boston backgrounds, not having a Boston background is okay with us.
Thank you.
And you have we have two guests as well. We have Dr. An in as well. Hi, David. How are you?
Oh, hello. I'm doing all right. Exciting panels so far.
And where are you sitting today?
I am in beautiful Newport Beach. I don't remember if I have a virtual background on, but yeah, so I'm in Newport Beach in California. Great weather, just sitting in my office.
Wonderful. So yeah, being in the Northeast where we just barely started seeing above freezing temperatures last week. Very jealous. Love Newport Beach. Have taken the family to Newport Beach on many a vacation in August when there never rains, and love the Newport Pier and all of those beaches there, especially when the kids were little. We also have David Kerr. Hey, David, how are you?
Very well, and thank you very much for the kind invitation.
No, thanks for joining us. And tell us, which part of the world are you in?
So I'm in Santa Barbara, California, where it's bliss.
Okay, so we're also jealous. Yeah, all right. So Joris and myself sitting up in the Northeast, and David sitting in SoCal. We are jealous of both of you guys. Let's just do like a 1 minute introduction of each one of you for our audience, so everyone knows your backgrounds and just what kind of role you're playing in this virtual first healthcare revolution that we're seeing, not just in the US, but as Silvana just pointed out, globally as well, like in Bangladesh with their $10 million raise from Prava Health. Joris, can you leave just a 1 minute background on what you do at Novartis?
Sure. Yes, Joris van Dam, my background is computer science. I started going into what we now call digital health almost 15 years ago now. I'll get back to that in a second. But when we discussed that in particular treatment situation, that good information, good digital health tools were worth more to innovating clinical practice than a new drug. So that's been our mission, sort of my wake-up call, if you want, that we could use computer science and digital tools for the benefit of patients to support public health benefits. That's been my journey since then. And for the past couple of years with Novartis, I've been leading our research efforts into digital therapeutics.
Fantastic. And Dr. An, a little bit of like 1 minute bio sketch on yourself.
Yeah, so I'm an adult endocrinologist. I'm the medical director of a diabetes center for Hoag Hospital, which is a large community hospital network in Orange County, California. Really passionate about diabetes technology. That's kind of what led me into endocrinology. And kind of in the 2010s, I was an editor for a blog called imedicalapps.com. So I got to have a lot of exposure to kind of the growth of the digital health ecosystem and have translated that to kind of my practice and my area of expertise, which is diabetes technology.
Fantastic. All right. And David, again, Santa Barbara, tell us a little bit about what you're doing in Santa Barbara these days.
Okay, so I'm a UK trained endocrinologist, internal medicine guy, but I've been in Santa Barbara 7 years as Director of Research and Innovation. I work at Sansum Diabetes Research Institute. We're a standalone non-profit devoted entirely to diabetes. As a non-profit, we range between feast or famine, often skeletal, but we've been around 76 years, so we must be doing something correct. I'm the digital health lead for the Diabetes Technology Society, and currently we're working with the Pass Up group to explore the use of digital technologies for underserved populations in the United States, including the use of wearable technologies and various other things. I'm also the co-author or co-editor of the first book on digital diabetes, which is available through Elsevier. That is called a plug. Thank you.
No, not a problem at all. It's always good to understand what people are working on. And so we'll go back up to the top of the Zoom board here as it's appearing in front of me with Joris. And Joris, tell us a little bit about what you see looking ahead over the next 3 to 5 years in terms of innovations in diabetes treatment and prevention that are going to have the biggest impact on and for patients living with diabetes.
Yeah, so Stan, if I may back up a little bit further to what we experienced in HIV about 15 years ago. So at that time, care of HIV was at a little bit of an inflection point. The 30 years prior to that had seen a tremendous amount of medical innovation, right? I mean, from the mid 80s when HIV was a virtual death sentence to early 2000 when HIV was a chronic condition, and there was just no reason to die of HIV anymore because the drugs and the intervention, that's how good they had gotten, right? Yet there were 2 million deaths every year. And when we had a discussion actually in a forum like this, very broad multi-sectoral discussion, and asked, well, what does it really take to make the next step in improving health outcomes for HIV? Nobody said a better drug. Nobody even said a cheaper drug. They all said more education, better connection between patient provider, and so on and so forth. So I was wondering, being much more of a novice to the diabetes field than the rest of this panel, are we arriving at a similar point in care of diabetes? And my curiosity was triggered by an article last year. I think the title of the article was, "What does diabetes care need? Does it need better drugs or does it need better services?" Right? And that was a very outspoken debate. And again, so on the surface, it looks like, and you know this much better than I do, on the treatment of diabetes, we have good medicine. By and large, we have good access to medicine, but I don't know, David, I'd be interested your perspective as well, how that is with underserved population. We have good interventions. We have good behavioral interventions. We know and there's no reason to die of diabetes if you have access to these medicines and interventions. Yet that is not mirrored by similar public health outcomes in terms of death annually in the US, in terms of the health outcomes, but also health economic burden of diabetes in the US. So have we arrived at a similar inflection point where the next gain or the next step or the next step change we're going to see in better outcomes for public health diabetes is not going to be about a new revolutionary medicine, is going to be about new tools? That's a question to you guys. And if so, what would those tools look like? So I think that's an open question, right? What does it take to really have that next step change in health outcomes for treating diabetes?
So can I jump in there?
Oh, please.
I would totally disagree with you about access to medicines. Mm-hmm. There's two problems. One is pharmacoadherence, and we know that in terms of diabetes, it's one of the worst offenders, with 25 to 50% of people never taking their medicines on any way of a regular basis, including insulin and type 2 diabetes. We also know that the cost of diabetes is a huge barrier for large swathes of the population. We do a lot of work with the Hispanic Latino community, where we're finding that people are borrowing, begging, buying, stealing, counterfeiting medicines in order to have some semblance of glycemic control. So many of the medicines are simply unaffordable. In the type 1 space, we are uncovering people rationing their use of insulin. So the challenge is actually that we have some good drugs available, but access to them is problematic. On a much more positive note, I am a strong believer that the digital health community have a great deal to offer, particularly underserved populations in the United States. And they are a huge market. And that's often forgotten in the current thinking, that there are a lot of people out there who would benefit from the use of digital health products, provided they are accessible and affordable. And we're finding that the barriers to the use of wearable technologies is actually incredibly low in these communities. There is a hunger for them to access these technologies. And I think the community, the digital health community, needs to come together and have a different way of thinking about these underserved populations.
And sorry, go ahead, please.
I would just definitely agree with that to some degree. I think it kind of becomes a situation of the haves and have-nots, both with respect to access to care, like Dr. Kerr is talking about, but also just kind of in the interest level and awareness level, right? So I think there are people that have good insurance that just for whatever reason, whether it's lack of motivation, lack of knowledge, just choose to not focus on their care. And so I think it's really, you're right in the sense that our tools are amazing in terms of medications and our devices. But I think, there's kind of the haves and the have-nots, are those that are caring about their health and not caring about their health. And I think it's really about increasing those that have access and those that are passionate about trying to improve their health.
There's also a problem of perceptions. I mean, this is heresy, what I'm about to say, but the biggest mistake in the area of glucose monitoring was the addition of the word continuous, which implies that people have to wear it forever with no beginning and no end. And we're seeing, certainly as the work we're doing here at Sansum, the use of CGM in the non-insulin treated population offers enormous opportunities to move beyond glucose as a metric for diabetes management and get into cardiometabolic disease, cardiovascular risk reduction, and also the mental health aspects. So I think the digital health community is at a very embryonic stage, but there's huge potential here.
Fantastic. So super insightful. You mentioned a couple of things, very helpful to understand the access barriers and cost perspectives, to better appreciate how digital health is going to help. So if we imagine a world where we can take down barriers to access, and we can take costs out of the equation. And you mentioned some of this already. How are the digital health tools going to help improve these outcomes, right? You mentioned pharmacoadherence, you mentioned motivation, caring about your health, you mentioned mental health aspect. What do you think is going to be, in the foreseeable future, the best tool in terms of public health outcomes for the patients that you work with, support, observe, treat?
Well, I have a bias because we are increasingly using CGM, say, in people at risk or with non-untreated type 2 diabetes. This opens up all sorts of potentials for the use for stratifying people into subgroups. One of the mistakes the digital health community has made, and this includes the therapeutic platforms, is that they know far too little about the user, and they have completely neglected the social determinants of health. And actually, access to the internet is another determinant of health. 1 in 4 Medicare beneficiaries do not have, don't have access. So one of the things that digital health is, that CGM is offering, is that you can get these subgroups where there are problems that are immediate and there are also long-term problems. And using this type of wearable technology, perhaps also in combination with fitness trackers, you can actually get into thinking about prescribing lifestyle as well as therapeutics. And there's nothing wrong with exploring the concept of prescribing a change in your step count or a change in the macronutrient content of your food. These are areas that are ripe for exploration with digital health.
Yeah, I think another huge offering that these digital care platforms have is just the way that they scale is just so exponential. And as you add in, you can add in layers of care that are automated, right? Whether it's chatbots or AI algorithms that are kind of triaging issues or numbers for physician extenders, and then you can triage that to physicians. And so I think just the scale is so massive that, and the costs are so low, relative to how all these non-health technology companies have really totally disrupted the market. I think potentially this is where these digital health platforms can provide a lot of care, improve quality of care at a much lower cost. Yeah. But I also agree with Dr. Kerr in that I think continuous glucose monitoring, or the intermittent use of continuous glucose monitoring, like he was alluding to, is, I feel like it's already kind of out of the closet now. Like everybody is already really excited about it, but I think that will just continue to grow. And I'm also very passionate about using it earlier and earlier, and even in people without diabetes or people with pre-diabetes. Exactly. I think there's a lot of potential there.
Yeah, there's also, the CGM has one of these tools that can do something different in diabetes care. It can solve a problem. And so people, I'm a clinician, I've been around 100 years, and one of the miserable things about diabetes is that it doesn't go away. And a lot of technology has been developed with a long-term view. But what actually people with diabetes want is to solve a problem. So if they're flying from Santa Barbara to Beijing, that's actually really challenging. And what to do with your insulin. If they're going for their colonoscopy, if they're type 2 diabetes and starting insulin. So one of the areas that I think are worthwhile exploring is the use of digital health to solve problems with a beginning and an end and in the short term. And the other thing that we're doing here is we're reducing dependence on doctors and and expensive clinicians. We're upskilling community health workers so that they can apply a CGM to people from their community. They can do a point of care A1C measurement. And in the United States health system, I'm from the UK, where I would say it's a much better system. One of the potential things that you could do in the US is to disrupt the current delivery of care by looking at what can be used in the community to improve access, knowledge, and use of therapies and devices.
And to build on that point, Dr. An, how do you see these tools fit in your practice? And maybe that has changed with COVID, right? I remember I already disclosed that I'm a tech nerd, going to my doctor. Yeah, but look at my step count, look at my this, and they just didn't want to, or he in that case didn't want to hear about it, right? Because I was using numbers out of context and so on and so forth. So this abundance, so it's not only scale, well, maybe thanks to the scale and cost, patients can gather a whole lot of data now. And what we as tech nerds do is we think, oh, fantastic, let's build a fantastic dashboard for Dr. An, so he can log in any time of day and see how his patient is doing. I bet you don't want that because you don't have time to monitor your patients. You're not a call center, right? There may be a potential liability impact. What if there is a blimp that you don't see, and so on and so forth? How do you fit these? How do you see these digital health tools fit in the way you treat your patients? And do you think that's changed or accelerated now that we are all going through a pandemic and are rethinking the patient-provider relationship?
Yeah, I'm sure this will be said 100 times today, but the pandemic totally changed the way that care is delivered, and in many ways that obviously benefited digital health so much, right? Because telemedicine is one of the key, and remote delivery of care is key to digital health. I think the downside to that widespread normalization of video visits and telemedicine is that I feel like there's a lot. I think people healthcare systems maybe get too comfortable thinking that they can provide digital care in a normal way just by offering video visits. But to kind of consolidate everything that you were talking about, I think one of the key problems that you're identifying in your question is that I think as healthcare systems and as a physician myself, I think we're very individual oriented, right? We're focused on the person in front of us. So the person calling my office, the patient that's in my waiting room. And while that's fantastic, obviously you want your doctor to care for you, I think it's very hard for health systems and doctors to have even a population based approach to healthcare, right? So I think we all know that population management and remote patient monitoring is this huge problem that needs to be solved. But even speaking personally, it's a huge challenge because we're not used to thinking that way as a provider. The reimbursement models necessarily aren't completely there. And this is where I think, once again, digital health can kind of come from the opposite perspective, because if anything, they have the opposite problem where they're used to looking at data, numbers at scale, patients at scale, and they're kind of focused on looking at it as at a system level to kind of fix the system. And so I think if you can kind of marry those two perspectives where you're keeping the individual in mind and not kind of neglecting the individual, but also forcing, the clinicians to think about it on a system scale, or maybe even the people that aren't part of the system yet, I think that's kind of the best of both worlds. But that's also the challenge, I think. But that's where I think we get really excited about the potential for digital therapeutics.
Fantastic. Stan, I could keep talking all day with these folks, but I'm so sorry that I've been hogging the discussion. Where are we?
I think this is fantastic. I think certainly we have, this is a very rich topic. We're going to have to come back to it and continue covering it next month. And so we'll have to invite you all back. But thank you again, Joris and David. Really appreciated. From a virtual round of applause from all of our attendees from all over the world listening now.